Before reviewing the graphics associated with mechanical ventilation, it's important to understand how ventilators deliver breaths. A mechanical breath is classified based on three main variables called phase variables. They dictate how the breath starts, how it's delivered by the machine, and how it stops. A breath can be started either by the patient called a supported or assisted breath, or by the machine called a controlled breath. This is known as the trigger. After the breath starts, the machine delivers gas to the patient in a set pattern throughout inspiration, which is called the target variable. The two main target variables are a specific inspiratory flow rate or a pressure goal. The breath delivery stops when a certain amount of time has passed, or the ventilator senses a decrease in the patient's airflow. This is known as the cycle variable. Any combination of these variables can define the type of breath delivered by the machine. Ventilator waveforms or ventilator graphics are graphical descriptions of how a breath is delivered to a patient. These include three scalars: flow over time, volume over time, and pressure over time, and two loops, pressure volume and flow volume loops. Graphics are waveforms that represent the interaction between the patient and the ventilator. The purpose of monitoring these graphics is to enable the interpretation, evaluation, and troubleshooting of both the ventilator and the patient's response to it. They help monitor the patient's disease status, assess their response to therapy, and ensure the ventilator is functioning correctly. Additionally, graphics allow for fine-tuning of the ventilator to reduce the work of breathing, optimize ventilation, and enhance patient comfort. Scalars on conventional mechanical ventilators are representations of specific respiratory parameters over time. The three scalars commonly utilized are volume, pressure, or flow plotted on the vertical y-axis against time plotted on the horizontal x-axis. Pressure and flow are measured values, while the volume of each breath is a calculated value. Each scalar represents the entire breath from the beginning of inspiration to the end of expiration. Most ventilators have these three scalars displayed on the main screen. Though I have shown these waveforms as an example for scalar waveforms, their shapes can vary depending on the mode of ventilation. During mechanical ventilation, scalar waveforms can appear in one of 6 basic configurations or shapes. I will just introduce them briefly here, and more will be discussed when we discuss individual scalars. The first type is the rectangular waveform, also known as the square wave or constant waveform. This waveform maintains a constant value over time, meaning that once a particular value is set, it remains stable throughout the duration of the breath. Such graphics are seen during pressure or volume control ventilation. The second type is the descending ramp, or decelerating ramp, which is characterized by a gradual decrease in value over time. This means that the waveform starts at a higher value and then slowly tapers off as the breath progresses. Next is the ascending ramp, also called the accelerating ramp, which is the opposite of the descending ramp. In this configuration, the waveform starts at a lower value and gradually increases over time, showing a steady rise as the breath continues. The fourth type is the sinusoidal waveform, often referred to as the sine wave. This waveform mimics the shape of a sine wave, creating a smooth, repetitive oscillation. It represents a breath that gradually increases and decreases in a rhythmic pattern, resembling the natural breathing process. The rising exponential waveform is the fifth type, and it displays a sharp increase in value, followed by a gradual plateau. This means that the breath delivery starts off with a rapid rise in value, which then levels off and stabilizes as the breath continues. Finally, the decaying exponential waveform shows the opposite pattern to exponential rise. It begins with a sharp initial value that quickly decreases, following an exponential decay. This type of waveform is typically seen when the breath starts at a high level and then decreases rapidly, tapering off as the breath completes. Generally, the ascending and descending ramps are considered the same as the exponential ramps. If you have carefully analyzed the configurations of 6 basic waveform patterns discussed earlier, you might have noticed that certain patterns appear only with some scalars. For example, square waveforms appear with pressure and flow, and descending ramps do not appear in pressure waveforms. So the type of waveforms also gives you an idea of the types of scalars you are looking at. Again, we will revisit all these waveforms as we discuss individual scalars and modes of ventilation. As discussed in the introductory video, pressure is associated with 3 types of waveforms, namely square, exponential rise and sine wave. We will not discuss the sinusoidal waveform as they appear with spontaneous unsupported breath. To understand the remaining 2, we need to look into the 2 control variables, which are volume controlled and pressure controlled. There is a separate videos for it, the link is provided in the description. In brief, control variables decides which variable to keep constant or independent, and depending on them, the other dependent parameters changes its value or shapes. The control variable is not mode of ventilation in itself, the modes of ventilation depends on both control and phase variables. Anyhow, as you can see here, the shape of the pressure waveform is square in pressure-controlled ventilation and exponential rise in volume-controlled ventilation. It's not just pressure waveform shape that varies, you can note the flow and volume waveforms change too. Now let's dissect the squared and exponential rise waveforms. The pressure waveform represents the pressure in the airway as a function of time. This can be a fixed or variable amount depending on the mode of ventilation. During pressure-controlled ventilation, the pressure delivered is constant and the pressure scalar is square-shaped. In volume-controlled ventilation, the pressure times scalar is exponential due to the rise in pressure with a constant flow pattern. We will look into the square pressure waveform here. As soon as the ventilator is triggered, be it time or flow trigger, the ventilator increases the pressure from the baseline PEEP to the set inspiratory pressure. This steep increase in pressure is immediate unless the pressure rise time setting is increased. The pressure remains constant through the inspiratory phase until the ventilator cycles back to the baseline PEEP pressure. The constant pressure throughout the inspiration is what gives the pressure waveform square shape. We can appreciate the advantages of square pressure waveforms during the modes of ventilation lecture. The pressure time waveform given here appears with volume-controlled ventilation where the flow and the volume is constant and the pressure changes depending on lung compliance. Because pressure keeps changing, the pressure waveform provides a lot of information during volume-controlled ventilation. The shape of this waveform is called rising exponential, which shows a sharp increase in pressure followed by a gradual plateau. In volume-controlled ventilation, the ventilator delivers air at a constant flow rate throughout the inspiratory phase. This flow rate is fixed regardless of changes in airway resistance or lung compliance. At the start of inspiration, the pressure rises quickly because of the airway resistance and stiff non-compliant empty lung. As the lung inflates, its compliance changes. Compliance increases as the lung volume increases, meaning the pressure needed to continue inflating the lung decreases progressively. This causes the rate of pressure rise to slow down. The pressure continues to rise until the preset tidal volume is delivered. Then the pressure becomes constant throughout the remaining inspiratory phase. At the end of the inspiratory phase, the pressure drops back to baseline or PEEP as the ventilator cycles to expiration. Now that we have learned how the pressure waveform takes its form, let's look into the important parameters displayed on it. In the typical pressure graphic, the baseline pressure indicates the post-end expiratory pressure PEEP, and the maximum pressure at the end of the curve indicates the peak inspiratory pressure PIP. In addition to the PIP and the PEEP, the pressure versus time scalar can show a few other pressure measurements when a specific ventilator maneuver called end inspiratory hold is performed. An inspiratory hold is a period during which the ventilator momentarily stops delivering air into the patient's lungs, effectively pausing the inspiratory phase of ventilation. This pause allows for the measurement of pressures in the airway and alveoli without the influence of airflow or airway resistance. The measured pressure is the plateau pressure, which reflects the pressure in the alveoli under a static condition when there is no airflow. And the pressure drop from PIP till the plateau pressure denotes the airway resistance. So basically, PIP is mathematically calculated by adding the pressure created by airway resistance, the pressure related to the lung's compliance or plateau pressure, and the total PEEP. There are numerous information we can get from the pressure time waveform. The first one is the detection of trigger mechanisms to let clinicians know whether the delivered breath is assisted or controlled. If the breaths are initiated at the baseline at fixed intervals, the mode is time-triggered or a control mode. In an assist mode, the patient initiates the breath by generating a negative pressure. This event can be observed on the pressure versus time scalar, where a small negative deflection below the baseline precedes a mechanical breath. However, we can ascertain this from the mode of ventilation we set on the ventilator without having to look at the waveform. There are lots to discuss about triggering when we discuss ventilator desynchrony. An increase in airway resistance can be detected on the pressure time curve during mechanical ventilation by observing several key changes. The peak pressure on the curve will rise because higher resistance in the airways requires more pressure to deliver the same tidal volume, leading to an increase in peak inspiratory pressure. The slope of the pressure rise also becomes less steep, indicating a slower increase in pressure, as increased airway resistance causes a delay in achieving the peak pressure. The plateau pressure might remain the same, but the gap between peak pressure and plateau pressure widens. This occurs because plateau pressure reflects alveolar pressure, which may not change significantly with increased airway resistance alone, especially if lung compliance remains the same. These changes help diagnose issues like bronchoconstriction, airway obstruction, or secretions in the airways. When discussing lung compliance in mechanical ventilation, plateau pressure is a critical parameter to consider. Plateau pressure is measured at the end of inspiration when airflow is briefly paused, allowing the pressure in the alveoli to equalize with the pressure in the airways. This measurement provides a direct reflection of the elastic properties of the lungs and chest wall, giving us insight into lung compliance. If lung compliance is high, the lungs expand easily, requiring less pressure to deliver the same volume of air. This results in a lower plateau pressure, which also reduces the peak inspiratory pressure unless resistance is increased. For instance, in conditions like emphysema, Where the lung tissue loses elasticity, you typically see lower plateau pressures because the lungs are more easily distended. In contrast, low lung compliance indicates that the lungs are stiffer and harder to inflate. This stiffness necessitates a higher pressure to achieve the desired volume, leading to a higher plateau pressure. Similarly, the peak inspiratory pressure increases if the airways remain the same. Diseases like ARDS, pulmonary fibrosis, or pulmonary edema, where the lung tissue becomes less compliant, will show elevated plateau pressures as a result. Monitoring plateau pressure over time is also valuable for tracking changes in lung compliance. If plateau pressure rises, it may suggest that lung compliance is worsening, such as in the progression of ARDS. Conversely, a decrease in plateau pressure could indicate improving lung compliance, perhaps as a response to effective treatment or resolution of the underlying condition. Double triggering occurs when a ventilator delivers two breaths in quick succession without expiration between them. This can happen in both flow-triggered and pressure-triggered ventilation. In pressure-triggered ventilation, the ventilator detects a drop in airway pressure caused by the patient's inhalation and responds with a breath. If the patient continues to inhale forcefully, the ventilator might misinterpret this as a new trigger, resulting in a second breath. Similarly, in flow-triggered ventilation, an increase in airflow to the inspiratory threshold prompts the ventilator to deliver a breath. If the patient's demand isn't fully met or they continue to inhale with significant effort, the ventilator delivers an additional breath quickly. The flow trigger can be detected on the flow time waveform. Double triggering can also occur with mandatory breaths if the patient's inspiratory effort coincides with the timing of the mandatory breath. In this case, the ventilator might deliver an additional breath if it interprets the patient's effort as a need for more ventilation. Several factors can contribute to double triggering. Short inspiratory time can lead to incomplete exhalation before the next breath is triggered, increasing the likelihood of double triggering. Additionally, settings such as high sensitivity levels or low trigger thresholds can make the ventilator more responsive to the patient's efforts, thus increasing the risk of double triggering. If the patient has a high respiratory drive or not sedated enough, their breathing patterns might become erratic or forceful, which can also contribute to the phenomenon. Double triggering can cause increased work of breathing and respiratory muscle fatigue. It may lead to overventilation, resulting in issues like hypercapnia or alkalosis. The risk of higher airway pressure can lead to barotrauma or volatrauma. Patients might experience discomfort and anxiety too. Auto-triggering in mechanical ventilation refers to the unintended delivery of breaths by the ventilator without an actual effort from the patient. This typically happens when the ventilator's sensitivity setting is too high, making it overly responsive to minor disturbances that are not true respiratory efforts. For instance, vibrations, cardiac oscillations, or leaks in the ventilator circuit can falsely trigger the ventilator to deliver a breath. On the pressure time waveform, auto-triggering is recognizable by the presence of additional breaths that do not follow the normal pattern of patient-initiated breaths. Normally, when a patient tries to inhale, a small drop in pressure occurs, signaling the ventilator to deliver a breath. However, with auto-triggering, this drop in pressure is absent. Instead, the waveform may show unexpected pressure increases at irregular intervals, indicating that the ventilator is delivering breaths independent of the patient's needs. Same thing can happen during flow trigger ventilation, but it is less than in pressure trigger. Auto-triggering leads to overventilation, patient ventilator asynchrony, delayed weaning, and increased risk of lung injury. In-depth discussion on auto-trigger is done in ventilator asynchrony video. Ineffective triggering is a condition where a patient on mechanical ventilation attempts to initiate a breath, but the ventilator fails to recognize and respond to this effort. On a pressure time scaler, this is observed as small, sharp dips or deflections during the expiratory phase that do not result in a full ventilator-assisted breath. These dips indicate that the patient is trying to breathe, but the ventilator does not deliver a breath, often due to factors like auto-PEEP or low trigger sensitivity. This can lead to increased work of breathing, respiratory muscle fatigue, and patient ventilator asynchrony. Delayed triggering in mechanical ventilation is a prolonged time lag between the onset of the patient's effort to initiate a breath and the ventilator's response in delivering that breath. The most common cause of delayed triggering is inappropriately low sensitivity settings on the ventilator, which make it harder for the patient to trigger a breath. Flow triggering typically requires less effort from the patient than pressure triggering, making it a better option for reducing the likelihood of delayed triggering. This delay can have important clinical implications, as it can prolong the trigger phase and increase the work of breathing early in inspiration, leading to patient discomfort and fatigue. Overshooting in mechanical ventilation occurs when the ventilator delivers a higher pressure than necessary, which is visually represented on the pressure time waveform as a sharp, steep rise that exceeds the target pressure before stabilizing or dropping back to the set level. This spike typically appears at the start of the inspiratory phase and indicates that the ventilator is delivering pressure too quickly or aggressively. Common causes of overshooting include a fast rise time setting, high ventilator sensitivity, and patient ventilator asynchrony. Clinically, overshooting can lead to barotrauma and patient discomfort. Air hunger, on the other hand, occurs when the ventilator does not meet the patient's inspiratory demands, causing a sensation of inadequate airflow. On the pressure time waveform, air hunger may manifest as a delayed or inadequate pressure rise during inspiration, where the waveform starts to rise but levels off before reaching the necessary pressure. Sometimes, there may be a noticeable dip or drop in pressure during inspiration, indicating that the patient is attempting to inhale more air than the ventilator is providing. Causes of air hunger include a slow rise time, inadequate pressure support, and issues with trigger sensitivity. This condition can result in an increased work of breathing and patient ventilator desynchrony. Auto-PEEP or intrinsic positive end expiratory pressure occurs when all the air is not exhaled before the next breath begins, leading to air trapping and increased pressure within the lungs. On a pressure time waveform in mechanical ventilation, auto-PEEP is evident when the pressure baseline does not return to zero or the set PEEP level before the next breath starts. Instead of the pressure dropping fully to the expected end expiratory level, it stays elevated, indicating that residual pressure remains in the lungs. This manifests as a persistent positive pressure during the expiratory phase and can sometimes create a stacked breaths pattern where one breath begins before the previous breath has fully exhaled. Auto-PEEP can arise from factors such as insufficient expiratory time, high respiratory rates, or airflow obstruction, as seen in conditions like COPD or asthma. Clinically, it can lead to increased work of breathing, hemodynamic instability due to intrathoracic obstruction of venous return, and difficulty in triggering the ventilator as the patient must overcome this intrinsic pressure before initiating the next breath. In mechanical ventilation, volume-time waveforms are used to visualize the delivery of tidal volume over time. The shape of this waveform can vary based on the ventilator's settings and the mode of ventilation. Two common shapes are the sinusoidal waveform and the ascending ramp waveform. A sinusoidal volume-time waveform resembles the shape of a sine wave. It gradually increases and decreases in a smooth, wave-like pattern. The sinusoidal pattern indicates a gradual and continuous change in volume, with no abrupt transitions, suggesting a more even distribution of air during the breathing cycle. This waveform is typically associated with spontaneous breathing or certain modes of ventilation that allow for a more natural flow of air, closely mimicking physiological breathing. An ascending ramp waveform, on the other hand, is characterized by a straight or slightly curved line that increases at a constant rate over time. This pattern represents a gradual increase in volume delivery, which is typically seen in controlled mechanical ventilation modes. The ascending ramp suggests that the ventilator is delivering volume at a steady, continuous rate until the target tidal volume is reached. This gives the waveform the typical mountain peak appearance. It may also have a plateau or flattened area at the peak of the waveform. During the flat or plateau phase, the volume remains constant, indicating that the lungs have received the full breath and no more air is being added. This happens at the end of the inspiratory phase, often during an inspiratory pause maneuver. Now, let's study why the volume-time waveform takes a shape of a mountain. During the inspiration phase, the ventilator delivers air into the lungs, which causes the volume to increase. In volume-controlled ventilation, this increase typically appears as a linear rise on the waveform, since the ventilator is programmed to deliver a specific volume of air over a set period. The slope of this rise can vary depending on the flow rate settings. A higher flow rate results in a steeper rise. In pressure-controlled modes, however, the rise in volume may take on a more curved or exponential shape with fluctuating tidal volume depending on the lung compliance and the pressure applied by the ventilator. The volume attained at the end of inspiration is the tidal volume. If there is a pause at the end of inspiration, known as an inspiratory hold, the waveform will display a plateau. This plateau indicates that the volume of air in the lungs is being held constant. This phase is useful for assessing plateau pressure, which provides insights into the lung compliance. When the ventilator ceases to deliver air, the patient begins to exhale, starting the expiration phase. During this phase, the volume of air in the lungs decreases as it is expelled, and this is reflected on the waveform as a downward slope. The steepness of this slope is influenced by the patient's lung compliance and airway resistance. In individuals with healthy lungs, the volume typically decreases smoothly and rapidly. In contrast, if there is increased airway resistance or poor lung compliance, the slope may be less steep, indicating slower exhalation. Finally, the volume returns to the baseline. In mechanical ventilation, the control variable in a volume-time waveform can be recognized by observing the consistency and predictability of the waveform. If the waveform remains smooth and steady during inspiration, followed by a return to baseline during exhalation, it indicates that volume is the controlled variable. This is because, in volume-controlled ventilation, the ventilator maintains a constant volume, leading to a uniform waveform. Additionally, while the volume-time waveform remains consistent, the pressure-time waveform may vary depending on the patient's lung compliance and airway resistance. In contrast, in pressure-controlled ventilation, the volume-time waveform may change with varying lung conditions, but the pressure-time waveform remains consistent, indicating that pressure is the controlled variable. An air leak in a volume-time waveform can be recognized by an abnormality in the expected pattern of the waveform. Typically, in the absence of a leak, the volume-time waveform rises smoothly during inspiration, reaches a peak and then returns to baseline during exhalation. However, when there is an air leak, the waveform will not return fully to baseline at the end of exhalation. Instead, it plateaus above zero, indicating that the expected volume of air is not returning to the ventilator. Additionally, the upward slope during inspiration may be less steep or show a slower rise as the ventilator compensates for the air loss. The peak volume may be lower than expected because some of the air intended for the patient is escaping through the leak. Air trapping occurs when a person cannot fully exhale the air from their lungs before the next breath begins. This situation is common in conditions like COPD or asthma, where airway obstruction slows down exhalation. On a volume-time curve, this incomplete exhalation causes the curve to not return to baseline before the next breath starts. The curve will often show a prolonged, flattened exhalation phase, indicating that air is still trapped in the lungs. Now, if you remember the volume-time waveform of air leak, it also causes the curve to not return to baseline. In an air leak, the curve fails to return to baseline because air is escaping from the system, leading to a loss of volume. This can cause a rapid decline or sudden drop-off in the curve depending on the severity of the leak. In air trapping, the problem is incomplete exhalation leading to residual air in the lungs. The curve flattens out as it approaches baseline but doesn't reach it because exhalation is cut short. So, while both conditions result in a similar-looking waveform, the underlying causes are different. Air trapping is due to incomplete exhalation, whereas an air leak is due to loss of air from the system. The subtle differences in how the curve behaves can help differentiate between the two. Active exhalation in mechanical ventilation occurs when a patient uses their respiratory muscles to forcefully expel air, rather than relying on the passive recoil of the lungs, for example with air trapping, patient discomfort or asynchrony. This effort results in noticeable changes on the volume-time curve. Specifically, the exhalation volume may exceed the inhalation volume, as the patient expels more air than the ventilator delivered. The curve might also display a steeper or more abrupt slope during exhalation and can drop below the baseline, indicating a negative volume shift. Furthermore, volume-time waveform can be used to detect patient ventilator asynchrony in conjunction with flow and pressure-time waveform. We will discuss asynchrony in a separate video. Flow-time waveforms in mechanical ventilation represent the flow of gas into and out of the lungs over time. Different types of flow-time waveforms are associated with various modes of ventilation and patient conditions. When the flow is directed into the lungs during inspiration, it is plotted as a positive value on the waveform because the flow is moving in the direction of the ventilator towards the patient. When the patient exhales, the flow reverses direction, moving out of the lungs and away from the ventilator. This reversed flow is plotted as a negative value because it represents movement in the opposite direction. We will concentrate on the inspiratory part here, as the expiratory flow is usually passive and same for all the different types of waveform with gradual decline to zero before the next breath. The square flow waveform is characteristic of volume-controlled ventilation, where the ventilator delivers a preset volume of air to the patient at a consistent, unchanging rate throughout the inspiratory phase. This constant flow rate is represented by a flat, horizontal line on the flow time waveform, indicating that air is being delivered steadily into the lungs. At the end of inspiration, when the ventilator stops delivering air, the flow rate suddenly drops to zero, which is shown by a sharp, vertical drop in the waveform. This abrupt change marks the transition from the inspiratory phase to the expiratory phase. This consistent flow ensures the full tidal volume is delivered but can increase peak airway pressures, especially in patients with stiff lungs. The descending or decelerating flow waveform seen in pressure-controlled ventilation and some volume modes starts with a high flow rate that gradually decreases during inspiration. This flow pattern improves gas distribution and reduces peak pressures. The accelerating or ascending flow waveform starts with a low flow rate that increases throughout inspiration. It is less common but may be used in specialized situations where an increasing flow rate is beneficial. The sine wave flow waveform gradually increases to a peak and then decreases smoothly, closely mimicking natural breathing and making it more comfortable for patients. It is used particularly during spontaneous breathing or pressure support ventilation. Finally, the exponential decay flow pattern seen in pressure-controlled ventilation starts with a high flow rate that gradually decreases as the lungs fill. This pattern, shown as a downward-sloping curve on the waveform, helps distribute air more evenly and reduces peak airway pressures, making it gentler on the lungs. It's same like descending pattern, except that the flow decline is descending ramp is linear at the same rate, whereas in exponential decay, the flow decline is gradual, giving it a curved appearance. We can distinguish between pressure-controlled and volume-controlled ventilation based on the pattern of airflow during inspiration. In volume-controlled ventilation, the waveform shows a square or constant flow pattern where the flow remains steady throughout the inspiratory phase, represented by a flat, horizontal line. In contrast, pressure-controlled ventilation features an exponential decay or descending flow pattern, where the flow starts high and gradually decreases as the lungs fill with air, resulting in a downward-sloping curve on the waveform. Missed triggering occurs when the ventilator fails to detect or respond to the patient's spontaneous breath attempts. If the ventilator is pressure-triggered, the flow time waveform will show a persistent flat baseline after expiration with no changes in flow despite the patient's respiratory efforts. The patient's respiratory effort will be visible as a negative deflection on the pressure time waveform. If the ventilator is flow-triggered, small bumps may appear after expiration, indicating the patient is trying to inhale. However, if the flow generated is insufficient to reach the trigger threshold, the ventilator will not deliver a breath. The causes of missed triggering include low sensitivity settings, which prevent the ventilator from detecting weak inspiratory efforts. Mechanical issues such as leaks in the ventilatory circuit or malfunctioning sensors, and patient factors such as very weak or irregular breathing efforts that might not be sufficient to trigger the ventilator. Delayed triggering in mechanical ventilation occurs when there is a noticeable lag between the patient's effort to initiate a breath and the ventilator's response. This delay, typically longer than 100 milliseconds, can manifest in the flow time waveform as a flat baseline that persists longer than expected after the patient begins to inhale. This will be followed by a delayed rise in the flow curve. The primary causes of delayed triggering include low ventilator sensitivity settings, the presence of intrinsic PEEP or auto PEEP, weak patient effort, and mechanical issues such as leaks or faulty sensors. Double triggering occurs when a ventilator detects two separate inspiratory efforts from the patient within a short time frame, causing two distinct peaks in the flow time waveform. To recognize double triggering on a flow time waveform, you should look for two prominent peaks that appear close together in time. These peaks indicate separate instances of inspiratory effort. The flow time waveform might show a noticeable irregularity or a change in the baseline between these peaks, reflecting the ventilator's response to these multiple attempts at triggering a breath. The causes of double triggering can include overly sensitive trigger settings on the ventilator, which may mistakenly detect minor fluctuations as separate breaths. Additionally, the patient's respiratory efforts could be irregular or rapid, leading to multiple triggering attempts in quick succession. Mechanical issues with the ventilator, such as problems with the sensors, can also contribute to this issue. Finally, patient discomfort or improper ventilator settings that do not match the patient's respiratory needs can cause the patient to attempt multiple breaths, resulting in double triggering on the waveform. Auto-PEEP or air trapping occurs when the lungs do not fully empty before the next breath begins, leading to a buildup of pressure. In the flow time waveform, this is identified during the expiratory phase. Normally, the expiratory flow gradually decreases and returns to the baseline before the next inspiration starts. If auto-PEEP is present, the expiratory flow does not reach zero before the next breath begins. Instead, the flow curve is cut off, indicating that exhalation is incomplete when the next inspiratory phase starts. Air trapping can result from inadequate expiratory time, increased airway resistance as seen in COPD or asthma, high tidal volumes, or a high respiratory rate. In mechanical ventilation, recognizing expiratory resistance on a flow time waveform involves analyzing the waveform during the expiratory phase to identify signs of increased resistance. A normal waveform exhibits a smooth continuous drop in expiratory flow. When there is increases expiratory resistance, the waveform generated will have low peak expiratory flow and the flow curve returns to baseline more slowly. The expiratory portion of the flow time waveform may appear concave or scooped out due to the increased resistance, especially in conditions like chronic obstructive pulmonary disease. If the expiration is cut short due to short expiratory time, then there will be air trapping or auto-PEEP that we discussed earlier. Bronchodilators are used to reduce airway resistance when this happens. After bronchodilator administration, the peak expiratory flow rate increases, indicating that the patient can exhale more forcefully and quickly due to reduced airway resistance. The duration of the expiratory phase decreases, suggesting that the airways are more open, allowing for more efficient exhalation. If the waveform had a scooped-out appearance due to prior bronchoconstriction, the concavity is reduced, making the waveform more linear. Additionally, the expiratory flow may return to zero more quickly before the next breath, showing that the patient can exhale completely within the given time frame. Zero flow state in mechanical ventilation refers to a condition where there is no air movement in or out of the patient's lungs. This typically occurs during the end of the inspiratory phase, when the ventilator has delivered the set volume or pressure and no more air is being pushed into the lungs. At this point, the ventilator's flow rate is zero and marks the starting point for expiration. If this zero flow state is extended compared to normal settings, it indicates that the inspiratory time is prolonged. The curve will show a longer horizontal segment at the baseline. Prolonged inspiratory time during a zero-flow state can increase mean airway pressure, which might improve oxygenation but also raises the risk of barotrauma and volatrauma. This condition can cause air trapping, leading to increased work of breathing and potential hemodynamic compromise. Further, the reduced time for exhalation can result in incomplete exhalation. Higher mean airway pressures may affect venous return to the heart, leading to decreased cardiac output and hypotension. While prolonged inspiration can enhance oxygenation, it may impair carbon dioxide elimination due to shortened expiratory time. The pressure-volume loop in mechanical ventilation is a graphical representation that plots airway pressure on the horizontal axis against lung volume on the vertical axis during the respiratory cycle. It begins at the lower left corner, representing the end of exhalation, and progresses counterclockwise during controlled mechanical ventilation. The upward portion of the loop represents inspiration, during which pressure increases as volume increases. The downward portion of the loop represents expiration, during which pressure decreases as volume decreases. Positive end expiratory pressure is represented as the point where the loop begins and ends on the pressure axis, indicating the baseline pressure maintained in the lungs at the end of expiration. Peak inspiratory pressure is the highest point on the pressure axis during the inspiratory phase of the loop, reflecting the maximum pressure in the airways during inspiration. The lower inflection point on the inspiratory curve indicates the pressure at which alveoli start to open and is useful for setting appropriate PEEP levels. The upper inflection point indicates the pressure at which overdistension of the alveoli begins, helping to avoid volatrauma. During spontaneous ventilation, the pressure-volume loop moves in a clockwise direction, contrasting with the counterclockwise movement seen in controlled mechanical ventilation. There are two types of resistance encountered during the flow of air into the lungs. They are inspiratory and the expiratory resistance. The inspiratory resistance occurs due to the resistance to the flow of air in the airway, whereas the expiratory resistance happens due to the opposition to the elastic recoil of the lung during passive exhalation. They reflect the resistive work of breathing and the elastic work of breathing, respectively. In a pressure-volume loop, inspiratory resistance is reflected in the slope of the inspiratory limb. A flatter slope during inspiration indicates higher resistance, meaning that more pressure is required to achieve a given increase in lung volume. This suggests that the airways are offering more resistance to airflow during inhalation, necessitating greater effort from the ventilator or respiratory muscles. Likewise, increased expiratory resistance is evident when the loop demonstrates a delayed return to baseline after expiration, making the expiratory loop wider. This delay suggests that there is higher resistance during exhalation, which may result in air trapping in the lung. Lung compliance refers to how easily the lungs can expand when air is delivered. It is defined as the change in lung volume per unit of pressure applied and is a key feature that can be visualized from the slope of the inspiratory limb of the loop. In increased compliance, as seen in conditions like emphysema, the pressure-volume loop will show a steeper inspiratory slope, thereby shifting the loops toward left. This means the lungs are more easily inflated with less pressure as the lung tissue is more elastic. On the other hand, decreased compliance seen in conditions like ARDS or pulmonary fibrosis results in a flatter inspiratory slope, thereby shifting the pressure-volume loop to the right. The lungs are stiffer, requiring higher pressure to achieve the same increase in lung volume. This is often associated with a higher peak inspiratory pressure and a risk of lung injury due to the increased pressure required for ventilation. Lower inflection point marks the pressure where alveoli begin to open or recruit during inflation. Before this point, the lungs are less compliant or stiff because many alveoli are still collapsed. The lower inflection point guides clinicians to set the minimum pressure like positive end expiratory pressure needed to keep alveoli open and prevent collapse during breathing. It is recommended to set PEEP above this point to avoid alveolar collapse. The upper inflection point occurs at the pressure where the lungs begin to overdistend, indicating that alveoli are being stretched too much. Beyond this point, the risk of lung injury from overinflation or volotrauma increases. Ventilatory settings should keep pressure below this point to avoid causing damage to the lung tissue. While the inflection points are useful for getting an idea of lung recruitment and overdistension, they are not precise and are difficult to measure. Lung overdistension on a pressure-volume loop manifests as a flattening of the loop at high lung volumes, forming a shape that resembles a bird's beak. This occurs because the pressure begins to significantly rise with no change in the volume. The excessive pressure can lead to potential lung damage as the high pressures stretch the lung tissue beyond its safe limits. Reducing the tidal volume delivered can correct this issue of overdistension. Leaks in the ventilatory circuit can lead to discrepancy between the amount of air delivered to the lungs and the amount of air returning to the ventilator. This is recognized when the inspiratory and expiratory limbs of the loop do not meet at the end of expiration, leaving a gap. The gap occurs because some of the inhaled volume is lost through the leak, resulting in less volume being exhaled. Flow starvation occurs when the flow rate provided by the mechanical ventilator is insufficient to meet the patient's inspiratory demand. This mismatch can cause the patient to exert additional effort to draw in more air, leading to discomfort and increased work of breathing. When this happens, scooped-out appearances of the inspiratory limb is observed. This feature indicates that the set flow rate is insufficient to meet the patient's inspiratory demand, causing the patient to generate additional negative pressure, increasing the work of breathing. Increasing flow rate can address flow starvation. Shortening the inspiratory time will also increase the inspiratory flow rate because the same volume of air needs to be delivered in a shorter period. Normally, the pressure-volume loop traces in a counterclockwise direction. A slight indentation or inflection at the very start of the inspiratory limb indicates patient's effort to initiate the breath, causing a brief drop in pressure before the ventilator takes over. If the ventilator is time or machine triggered, the inspiratory limb begins smoothly without any initial dip or indentation. A flow-volume loop is a graphical representation used in both ventilator graphics and pulmonary function testing to visualize the relationship between airflow and lung volume during a respiratory cycle. Flow is plotted on the y-axis, representing the rate of airflow into and out of the lungs, while volume is plotted on the x-axis, representing the amount of air in the lungs. In a flow-volume loop, the inspiratory phase is displayed above the horizontal line and the expiratory phase is displayed below the horizontal line. The shape of the inspiratory curve reflects the settings of the ventilator, showing how the breath is controlled. When assessing the lung function of a spontaneously breathing patient, the flow-volume loop runs in the opposite direction. When there is leak in the circuit, the expiratory limb may not return to the zero, indicating that not all inspired air is exhaled through the circuit. A significant decrease in the measured tidal volume can also indicate a leak, as some of the air escapes before reaching the patient's lungs. Additionally, A lower than expected peak expiratory flow may be observed if air is leaking out before it can be exhaled through the ventilator circuit. A key indicator for airway obstruction is a scooped or concave shape of the expiratory limb, suggesting difficulty in expelling air due to obstruction. Additionally, a decreased peak expiratory flow indicates a reduced maximum flow rate during expiration, which is a common sign of narrowed airways. The expiratory phase may also be prolonged, with the expiratory limb of the loop appearing longer and more drawn out, reflecting the extended time needed to exhale air through obstructed airways. Air trapping in mechanical ventilation occurs when there is incomplete exhalation of air from the lungs before the next breath is delivered. This often results from a combination of high airway resistance and insufficient expiratory time. A flattened or scooped-out expiratory limb of the loop is seen because the patient is unable to fully exhale due to trapped air. There will also be increased end expiratory lung volume, leading to a shift of the entire loop to the right. The loop might appear to be stretched or widened horizontally compared to a normal loop. Airway resistance as a result of obstruction due to sputum or secretions is recognized by the sawtooth appearance of the loop. A smoother loop verifies that the suctioning of secretions has cleared the obstruction. A lung function test with a flow volume loop is used to assess respiratory function by measuring the volume of air a patient can inhale and exhale, as well as the speed of airflow. Depending on the location and the pathology, the flow volume loop helps in the assessment of the disease. I won't discuss on it as the lung function testing deserves the separate video in itself.